Assalamu alaikum. Good morning, everyone. Now we will start our second session. And in this session, our speakers will talk about sexual transmitted infections and mucosal diseases. And it's my pleasure to introduce Dr. Mihail Skerlev, Department of Dermatology and Venereology, Zagreb University School of Medicine, Zagreb University Hospital, Croatia, Head of the Outpatient Center, Polyclinic of the University Department of Dermatology and Venereology, STD Outpatient Center Division of Pediatric Dermatovenereology, and Head of the Reference Laboratory of the Ministry of Health and Social Welfare, Republic of Croatia for Dermatological Mycology and Parasitology. Welcome, Dr. Mihail. Can you start? Dr. Mihail will talk about recurrent herpes genitalis, treatment recommendations, and implications.
Well, thank you very much for this introduction. And since, due to some technical circumstances, we do have a little bit more of time because, best to my information, the second lecturer will not be here. Well, I think that meanwhile, it will be a little bit more of the audience here because they usually drop one by one, you know, in this way. But anyway, thanks a lot to all of them who are here. And first of all, thanks so much to my hosts, to dear Professor Ahmad and to Professor Nisha Parmar for having kindly invited me, not for the first time. Well, not for the first time, I think it's the third time for this conference, but I've been many times to Dubai teaching on, lecturing on the mostly STIs topics even from before. So it's really my great pleasure, and I feel I'm almost at home. So thank you for that. Besides, this is a part that we really have to be proud of. Mohammed, Professor Ahmad, I have just said thank you to you, so that you know that I said thank you also to Professor Ahmad. And I realize, you know, when you are the host of the conference, you all the time, everybody asks you something, pulls you on your hand and so on. So I'm most grateful that you found your time to be here and that you have again invited me to this lecture. But anyway, best to my understanding and best to my experience, and all of you who are here in the room can be very proud that Professor Mohammed Ahmad and Professor Nisha Parmar are excellent ambassadors of dermatovenerology in Emirates throughout the Europe and world, because I have met those celebrities all around the Europe and world. So it's not only the Galadari dynasty, it's also the other very dear colleagues. And I see also in the second row here my very good friend who really has a very great interest for sexually transmitted infection. And I found the kind of answer to your question from yesterday, if possible. So I'm giving a little bit more time because I get the people to come in and we have a little bit more of time. Of course, I have no conflict of interest for this particular talk, although I've been involved with some sponsorships from before. And, you know, by this slide, I wish to say that the way of sexually transmitted infection is mostly sexual. Okay, there are some examples of non-sexual transmission, but that's comparatively rare. So usually you won't get STI from the virus from computer. Although, if the patient feels more happy that it is from the virus of computer, from the bed linen, from the toilet whatever, leave the patient into that dream. Don't don't disappoint the patients. Because, sometimes some kind of lies are very, convenient. Unfortunately, a lot of our life consists of some kind of small lies. Oh, how nice meeting you. Oh, it's so nice you come. Won't you stay a bit longer, and so on, which are the typical, bullshit or typical lies which make our life more easier. From the professional part of the life, even the patient knows that this is mostly sexually transmitted. We are not policemen, we are doctors. So we have to get the history of the patient. Once you block the patient and you say, even by your body language, what have you been doing? You get the patient back and you wouldn't get the patient's history. So one of the most important thing in doing venerology is to get this specific patient-to-doctor relationship. Otherwise, we will not get the history. And then again, we can never know for sure because we only hear one side of the story. That's what patient tells us. And God knows what is the truth. So try to make the patient tell you the contacts, try to make the patient do the workup, try to make the patient to let the other persons involved get treated, but never judge the patient and never make the patient feel uncomfortable. That's one of the elementary prerequisites if you want to be a good venerologist. And since I love you very much, which is not a lie, I'm sharing those with you because you are very brave, and the Professor Ahmad doesn't know the secret that this is going to be the best session of the whole Congress ever. So I know that Nisha is over there with onycholysis, and I've heard Dr. Ali talking about interesting things, but such an audience, and we should be much better. So that's our small secret. And of course, if you ever happened not to be in Croatia, I know that Professor Ahmad has been, and please correct this immediately. Well, it's not that easy, but it's not that complicated because it's a small country, but very, different. It has seaside, mountains, and capital. So, try to be there. Anyway, now, we talk a lot about herpes simplex virus 2 and 1. Well, there are some differences, as you can see, but I don't insist on these differences because more and more we've got a mixed situation. We've got a typical genital herpes caused by herpes simplex virus 2, and we've got oral labial herpes also caused, by one, and it is all mixed. So it is still mostly one oral labial and two genital, but don't be completely strict to that because this has changed. Due to many things. It's also kind of evolutionary changes. It is also due to oral sex, but not only that. So this situation has changed. And, it's not very easy to make epidemiology. Because, we have been used that we report the disease based on the, some kind of laboratory finding. So we isolate Neisseria gonorrhea, we say we have that many gonorrhea. We isolate, we got a positive serology for syphilis, but what should we report on herpes? It's mostly based on the clinical features, because not all the time do we make PCR or antibodies, and it is in particular difficult for my narrow field It's HPV, but as I've talked about HPV a lot, because it is very difficult to know. So anyway, as you can see, it is really the highest incidence in sub-Saharan Africa, and we've got a very high incidence of herpes throughout the world. And this is a very, very old study. You know, I like the fashion, but we also have to like the background and tradition. This is an old study made in Scotland, indicated that there is more and more mixed of this herpes simplex virus 1 and 2 infection. So these were the grounds, and then, okay, we had a lot of studies afterwards which made the situation different. Now, these are some of the reasons why it is so. Because we know in herpes it is most important the latency period, and then again, as we know, a lot of asymptomatic situation. So that's why this is one of the reasons. However, this can be a little bit taken off today, and HPV is the most frequent viral infection. One of the reasons that there is effective treatment against herpes virus, and unfortunately, as yet, there is not etiological treatment for human papilloma virus. So it is a little bit different. And as you can see, it's not only, the burden, it's also extreme cost for the health authorities. So it's a great cost throughout the world. And now, this is a kind of, as I told you, the mixed and situation that even the newer references, we feel the participation of herpes simplex virus 1 in genital herpes. And it's definitely, first of all, it is not just another STI. The person with genital herpes of the recurrent phase in particular, it's a really very great psychological distress. Because, living the life, oh my God, is it going to happen again? Because as we know, sometimes there are persons with 5, 6, up to 10 or 12 recurrences per year. And it's horrible feeling. Is it going to happen again? Am I going to be able to have a normal sexual relationship? What about my sexual partners and so on? So this is psychologically very, very difficult situation, and we can help the patient. First of all, not only by giving the pills, but also reassuring the patient that this patient can be helped. And in between, when the patient doesn't have symptoms, the patient might have a normal sexual life. So this is quite important because they got severely depressed with such, a large number of recurrences. So, as I told you I love you, and it was not a lie, I will share with you some of the photos from my personal photo archive during my work in department. Well, different types of, we are dermatovenerologists. So, as we all know, these are the phases of, oral herpes. I know that you know, but just sometimes let's go to the basic, dermatology. The old clinicians taught us that the main difference sometimes, not in this case, but sometimes between zoster and herpes is that in herpes you've got many stages of the inflammation in one very time. So you can see the patient with vesicles, erosions, and crusts. Whereas the patient with zoster has phase by phase. You can see erosive phase, you can see a crusted phase, but very rarely all together. Deliberately, in the situation of the computers and artificial intelligence and laboratory work, I wish to bring to attention the necessity of the knowledge of the basic dermatology. Because nothing and nobody can replace a good knowledge of the basic dermatology. So don't think that either computers or laboratory tests, which are excellent, but I try to teach my students, and so would you, that they should always know the basic principles of our beautiful dermatology. As you know, this is eczema herpeticatum. It used to be called eruptio variceliformis caposhi. It is the old term. And on here, you can see this. Actually, this was from the time of the analog photography, if you remember. You are all young here, but I think that you remember, these photo cameras, then you take the film, then you develop it, etc. So it was from that phase, because it's a very rare situation. In vesicles, you can catch the patient very, very difficultly, because these vesicles get broken very easily, and you got the erosive phases. So good happiness through love and vesicles get broken very easily. So that's why we should always, remember it. And this is quite common. You can see very often all kind of secondary infection, pyodermia or whatever in herpes. This is not a problem. It is most likely primary infection because we have both sides and so on. But look, not only, let's also have another myth. Not only primary infections, not all, necessarily mean that the patient hasn't been infected by the virus from before. So one person might have infection with the virus, and then the primary diseases gets exacerbated, even years later in the life. Afterwards, it's going to be recurrences. But the primary infection is usually more severe. And now, as I told so much about relationship with HPV, I just want to tell you that please be proudly dermatologists. For example, if you see the patient like that, to everybody it is quite clear that this is the condylomata, this is the human papillomavirus infection. No problems about that. But look at the patient carefully. The same very patient had two diseases at the same time. This was herpes. So, be proudly dermatovenerologists, because not everyone could establish the clinical diagnosis as easily or as it's our responsibility. So this patient had two diseases at the same time. They used to call it very academically in the Middle Europe casus duplex, meaning it's a case of a two situation. This is HPV, but also herpes. Okay, these are some of the typical situations, I know that you know. As I told you, in different phases. And then here, what could have been differential here? What do you think? Exactly, thank you very much. I knew whom could I trust. So it is definitely one of the potential. Well, it is a little bit, this reddish circle. These are here about 5 to 6 erosions, but it can be also multi-chancre disease. So syphilis 1 would be the first differential diagnosis. Very teeny lesion. Just go see on the left-hand side a very small erosion. So not everything is like in the atlas. The diseases haven't read the books. So the diseases sometimes behave out of our control. Of course, it's a different situation, as we can see. Well, by the way, I was telling about zoster, and I told you the differential. Well, this is only one of the differential, not everything. And of course, as our esteemed colleague has said, as we have all said, we have syphilis 1 as a differential. Well, that's another pearl city in our southern Adriatic, is Dubrovnik. Well, everybody, I have to agree, everybody pronounces it Dubrovnik, which, we get mad. But anyway, if somebody would say Dubai, it's not Dubai, it's Dubai. So it's not Dubrovnik, it's Dubrovnik. But anyway, I am happy Dubrovnik is the most important thing is that everybody comes there. It's a nice, beautiful city. Now, we have also, armamentarium. So, fortunately, as I've told you, we've got the tools against herpes. It's basic. And by the way, nobody, neither in America nor in Great Britain, where the centers for herpes are right now in India, has established when it is written with Y, when it is written with I.
Doctor.
If you can write acyclovir or valacyclovir, anything you want. Sometimes with epsilon, with Y, sometimes with I. I'm personally extremely sensitive.
Excuse me, doctor.
To the good situation.
Doctor, time.
Yeah.
I am sorry. Time finished.
Sorry.
Time finished.
No, I didn't. I haven't heard you.
Yeah. You have what?
I have you said something or no?
No, time of the lecture is finished.
No, but I extended it because we have another second talk. Is not here.
Finish maybe 5 minutes more. Yeah. This first lecture.
Because the second lecture is not here.
We continue syphilis 1. Yeah.
I didn't. So do we have the second lecture or no?
Yeah, we have. But first one finished. Yeah. Okay.
Because I've heard that the second lecture is not here. Is it true?
Here, yeah. The second lecture will continue because Dr. Zohdi one cancelled.
So we have a little bit more time.
Yeah.
Otherwise, I would have shortened it.
But
I got the information that I can a little bit surpass the time because I will go on one talk after the other. Okay. Otherwise, I would have been on time. So we have this kind of treatment, which is either episode or a suppressive treatment. Episode treatment meaning that we give. Now, there are many recommendations. It was the most classical 5 times daily per 200 milligrams or 400 milligrams 3 times daily. So these are some of the recommendations for the treatment. And of course, the secret of the genital herpes is suppressive treatment. So it means we give it for a longer period of time, up to, nobody can say how much, 3 months, 6 months, 12 months, as long as it takes. Meanwhile, the patient is free of symptoms and the patient doesn't spread out disease. So we get against viral shedding and against the patient. So this is another possibility. How can we, 2 days treatment? There are a little bit more regimens for acyclovir treatment. Valacyclovir has also, as you can see, episode treatment. It means we give it for 3 days, or we can give a suppressive treatment. And we have a lot of evidence to support this hypothesis. Actually, valacyclovir is derivate of acyclovir. And there is a third one, there is famciclovir, and this has, the treatment as it is written here. If we give it for a couple of days, 1 day now, or we can give it as a suppressive treatment. And there are some new substances, that's written here. Also copper oxide nanoparticles, but then again, these are the substances, these are not as accepted and approved as these 3 antiviral agents. It is a lot of papers. I could have given only lecture about HIV association, and this is important. And it was the classical experiment with a large bunch of women in Kuala Zulu in South Africa. They have given him anti-HIV substance topically, and the result was very good. And we really, as I say, giving the patients the treatment, we prevent the spreading of the disease. It is the northern part of Adriatic. Actually, we do not have developed HSV vaccine as yet. And these were today's field of expertise. So we have these fields of expertise today, these 3. And as you can see, there is International Herpes Management Forum. We've been working together. There is also Professor Raj Patel from India, Great Britain, and David Lewis. Definitely still condom, wear condom. Condom during the phase of infection, not all the time. As I said, the patients are stigmatized. We need to have STI education. Because, the good physician treats the disease, but the best physicians, as all of you are or would become, treats the patient who has disease. Join us if you want. In EADV, we've got HPV task force. You are most free to join us. We have had a very successful Congress in Zagreb, INT'L Europe. And this year, INT'L Europe is in Athens. And by this slide, for this moment, I'm most gratefully thank you for your kind attention. And I wish you all to have such a nice massage like this squirrel you deserve. Thank you very much.
Thank you, Dr. May. Thank you for the nice presentation.
Okay, do I stay here?
Yeah, I will continue with Dr. Miail. He will talk about the great imitator, my syphilis atlas.
Okay, thank you very much. That's why I have a little bit extended that, because I knew. Well, actually, when I was given this task, by Professor Ahmed, I said, oh my God, what am I going to do? I don't have my private atlas. But then again, finally, it's again the same story. But it is now something else I really wish to express here. More and more, we started to write dermatovenerology with dash. I don't like it. Because once we admit that we separate dermatovenerology, it means that little by little, this is going to be taken away from us. And we shouldn't allow it. Because, everybody wants to take the part of our beautiful profession. Surgeons want to take dermatosurgery, allergologists want to take inflammatory diseases. So please don't let infectologists or anybody else, with all the respect, to take away our... So I'm not very happy about this dash. And definitely, the disease that unites dermatology and venerology is and used to be syphilis. Because, these big departments in Europe, in Munich, in Paris, in Vienna, in Zagreb as well, they were due to syphilis. Because at that time, there was no effective treatment against syphilis. So syphilis patients were the reason for the big dermatological departments in history. Is it old or new? No, the life hasn't begun with us. So it is definitely an old disease, And as we know, there are two origins. Some people think that, some authors think that it has been in Europe. Some authors think that it has been transmitted from America by Columbus sailors. Well, this seems quite unlikely. The disease has most likely been. I'm so happy that my dear friend Dr. Ali is coming now. And by the way, he had excellent lecture on the nails. And I almost stayed there. Now we go up and see, what about this? Now we see Old World. It seems that the origin is Mediterranean. And there is some evidence that it has become from a Mediterranean. Okay, some evidence that, many years ago, there is some skeleton of the congenital syphilis. So nothing without Mediterranean. Well, fortunately, today, we do not see any more features like that. These were the historical features of the tertiary syphilis, which fortunately, or at least we wish to believe so, doesn't exist today. And this is now, again, this hypothesis, Columbus, not Columbus, Mediterranean, not Mediterranean, but we won't go into too much. Well, just I think that even in these parts, there are some cases of endemic syphilis. These are about examples of non-sexual transmission, because it can be transmitted like that. It can be by the use of everyday objects. The last one was on the border of Slovenia and Croatia. It was called morbus Škrljevo or Skerljevo, but definitely nothing to do with Skerlev, because Professor Michel Joignet, who is one of the greatest syphilologists, retired and not so active anymore, from Paris, he always thought that it was named after me. Well, honestly, no. Now, we have to see that it is still, there is a rising incidence of syphilis. But just please be careful about the numbers, because as usually, statistics is lying. It is a great progress and a greater, increase in frequency. But the basic number was not that high as in chlamydia or in HPV. So when you have 200% or 100% rise, yes, but the basic is not. Still, it is a very important disease, but today in the 21st century, it's not that frequent as some viral disease or chlamydia. Just let's have the common sense. So it is definitely very, very important, and of all age groups. And, it is also, I just point out, and I don't want, I've never ever read the slides with the audience, because I definitely believe that the audience knows to read. So these are some of the reasons, and that was the kind of a title I have been given. The syphilis, a great imitator. Actually, the original term is la simulatrice grande, and it means that it can imitate definitely any dermatosis. And that's what we have to be very careful about. These are some of the reasons why it is still very important. Definitely it's PrEP and PEP, because it's not so bad to give the potential candidates who want to protect themselves against HIV kind of PrEP treatment or PEP treatment. But those patients then do not use condoms, and then some of these disease gets spread. And of course it is now illicit drug abuse, and as you know, chemsex, which has become very popular, and this all contributes to the high incidence. So on PrEP users, the high incidence. And these are some trends. you know, especially among adolescents. Adolescents is a very important group of our patients, so never underestimate adolescents. And these are some of the changing epidemiology. It is very, very new. Now, okay, still, the greatest number, it's in MSM community, men having sex with men, but not only, so don't deceive ourselves that syphilis is going to be spread again only in this community. So it is still very important. Now, it is the classical manifestation. Eroded chancre, it's, well, it still exists, but it is a kind of, you know, classical clinical features. And deliberately, if you remember in my previous talk, when our colleague over there, very good, said that syphilis 1 is differential to herpes, we have a multiple chancre situation, and please try to, but you know, whatever you do, it can be multiple. It's usually the border is very firm, and usually the patient doesn't report the pain or doesn't report a kind of uncomfortable feeling. Whereas in herpes, but not in recurrent herpes, in primary herpes, usually it's painful and the borders are tender. These are some of the situation. And by the way, today in particular, we can find eroded chancre any place, not necessarily on the outer genitalia only. So please examine the patient carefully. And if you happen to have the patient on the tongue or the anal region, or at least, this is my experience, don't insist in the history by asking the patient, oh, how come you got the disease there? What have you been doing to have the disease there? Because the patients will be very uncomfortable. This is something that, you know, today we should be aware of, because we very often misdiagnose them as the genital warts. Condylomata lata are the manifestation of the secondary syphilis. Well, this is very rarely. And that's what palms and soles. But honestly, nobody could have seen from this. This is very discrete features. This is a little bit more. Now, whatever it happens on the body, because as we say, syphilis is la simulatrice grande, always pay attention to soles and palms. Now, well, in this context, this is easy, but it was a 32-year-old patient who came with this situation, and he was almost treated like genital warts, because it looks very much like perianal genital warts. What do you think it was? Sorry? What do you think it was? Exactly, it's a condylomata lata. I mean, something went fishy to me. Then I didn't go on with the treatment with cryotherapy and whatever, because it would be not good. I made a serology, and finally it has been relieved that it was condylomata lata. It was a part of syphilis 2. Because the treatment is completely different. And look, after one injection of extensive benzathine penicillin 2,4 million international unit, we got such a result, which would have never ever happened if it were genital warts. So please, if we are not confident, let's do the syphilis serology. With a negative syphilis serology, this wouldn't have happened. Okay, you can also do biopsy, then you will find the plasma cells and so on, but that's another story. However, syphilis serology is quite helpful. Exactly. This is more and more, but we don't have time for that. We don't have time. So we have a lot of emerging cutaneous presentations today. Congenital syphilis is very important. Now, okay, as we know, I won't go into the basics. We have to have so-called detective tests and confirmatory tests, and we always combine non-treponemal and treponemal. And there are certain differences between CDC, but it's not so important. Anyway, it's always, you know, the combination. That's important. Not, we didn't, and it was popular, but then they took it back from America. We don't like to establish the diagnosis of syphilis based on only one test. It should be at least a combination of tests. And these are some things that today they want to make it very sensitive. They make it work very, you know, next generation, very, very specific. Anyway, and the point of care is very good because this is what we do on the field. Point of care is always important. Sometimes not enough. So I have nothing against these rapid tests that have been done throughout the world, because this will make the patient come and get tested. But afterwards, if we want to really, you know, see what's the stage of the syphilis, then we make more precise. So regarding this, look, still, the mainstay of treatment is extensilin. So it is still, nothing has been surpassed. We have a lot of attempts of other antibiotics, but nothing works as well as this one. And okay, we can, there are, you know, guidelines. It's normally one, but we shall see that.
Excuse me, doctor, you have 1 minute. Okay?
Yes, but then again, as I told you, I can see what's the problem.
Yeah, because first lecture, you take time for 2 lectures. Now this is the 3rd one.
I mean, do we have or we don't have time? Because I saw you said like that. But I was told that the second speaker is not here.
But already first.
Okay. I was here.
I am sorry, doctor. Thank you for the excellent presentation.
So I would have finished. I have still 5 seconds.
6 seconds.
So you didn't have to warn me in particular. I am very much now it's up. I'm completely aware of that.
1 minute, yeah.
Yes. Okay.
Thank you, doctor. Thank you. It's my pleasure to introduce Dr. Suhail Al-Ahmed. He's a professor at the University of Sharjah and a consultation in oral medicine at the University Hospital Sharjah. He received in his baccalaureate degree in dentistry from the University of Jordan and his diploma in forensic odontology and clinical doctorate in oral medicine from the University of Melbourne in Australia. Dr. Suhail will talk about practice guide to oral biopsy. Welcome, Dr. Suhail.
Thank you. Okay, good. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for the introduction, and I would like to thank Professor Muhammad Ahmed and the organizing committee for inviting me for this conference. This is my 2nd time in this conference, and the topic that I was invited to present is Practical Guide to Oral Biopsies. My background is in dentistry originally, but my specialty is in oral medicine. So I do a lot of oral biopsies to reach a diagnosis for many of the oral mucosal lesions, many of which are also related to the skin diseases. So I have nothing to disclose with regards to this presentation. I give my acknowledgement to the institutes where I have worked and where I have seen patients, and the cases that I'm going to present today have been collected in those 3 institutes, and the patients whom I'm going to show the images of today have given their prior consent to use those images for academic purposes. So we do have a problem with the late diagnosis. We know that late diagnosis is detrimental to the patient's well-being. We know that diagnosis can be delayed, either due to not performing the proper investigations, including the biopsy, or because the biopsy has been done but has been done inappropriately, in a way that did not allow the clinician to reach a conclusive decision regarding the care for this patient. And this has been proven in the literature in a number of studies that show that specifically when it comes to the oral cavity, there is an actual delay in the diagnosis. For vesiculobullous diseases, the average delay in diagnosis is 8 months. For Sjogren's syndrome, it's up to 6 years. For the mucous membrane pemphigoid, up to 12 months or more. For oral cancer, it is 2 to 3 medical or dental visits before the diagnosis is made and the patient is put on the correct track. There are a number of reasons that have been attributed to this. Some are related to the patients who assume that this is a transient condition that will go away by itself, or they find it more convenient to get the medicine in the pharmacy without the proper medical consultation. There are also profession-related delays in which the clinician finds some lesion but assumes that it is again a trivial transient infection or inflammatory condition, and decides to either dismiss the patient or to have a watchful delay, but this also falls under the delay. Again, from the examples that I'm going to show you now, there are a lot of overlap between normal variations as well as the various conditions. So to build on that and to proceed with this presentation, we have this outline. So first we're going to talk about the when to perform a biopsy, what sort of conditions that needs to have a biopsy performed, how to perform a biopsy. There will be some practical tips, and that's specifically for the oral mucosa, and then precautions to be taken during that. So let's start with the first item. We have a number of conditions, lots of conditions in the mouth that do not require a biopsy. So atrophic candidosis, if there are predisposing factors, we don't need to take a biopsy. You can do a smear and culture it, but a biopsy is not necessary. Conditions that are geographic tongue or aphthous ulcers or some atrophic changes, depapillation of the tongue is not necessary. Pigmentation, if it is related to some dental causes such as amalgam tattoo or related to familial racial pigmentation or physiological pigmentation, that's not necessary. There are also white lesions in the mouth that appear to be worrying at the beginning, but they're not really that worrying, because we can establish a cause-effect relationship. The cause can be dental trauma from the teeth, rubbing or doing some physical friction on the mucosa. No need to do a procedure for that, because all you see is just hyperkeratosis. Or some patients will apply some chemical material in the form of medicament to relieve some dental pain or gingival pain, and this too will result in some reactive keratosis, which does not require a biopsy. Other white lesions that do require a biopsy are characterized as such. They are well demarcated, they are homogeneous in their appearance, they are slightly raised, slightly rough. So we worry about the possibility of potential malignant transformation in those lesions. So they need a biopsy. The distinction is obviously depending on the clinical presentation, the history, the overall expertise of the clinician to decide whether this is reactive keratosis or whether this is beyond that and requires assessment at the histological level. 3 pictures, 3 tongues, same side of the tongue, same clinical presentation, white patches in all of them. However, the differential diagnosis was, the diagnosis for the 3 of them was completely different. One was hyperplastic, hyperkeratotic, the other one was moderate dysplasia, the other one was squamous cell carcinoma, although they present the same thing. But how do you tell that this is a serious condition and requires a biopsy or requires further investigations, or it is not? Here are some tips. If the border is well demarcated, sharply demarcated borders, then you definitely need to worry about that. If it is blending with the normal tissue, this is probably reactive from trauma. Could be physical trauma from the sharp teeth, or could be chemical trauma from any products that the patient has been using. If the lesion is slightly raised, slightly rough, also this is something that you need to take into consideration. Non-homogeneous lesions, so a bland white is okay. Some alterations in the color showing some red spots is not okay. If it is in a high-risk site, so in the oral cavity, we have a number of areas that we consider high risk of malignant transformation. Those include the lateral tongue, ventrolateral tongue, floor of the mouth, and retromolar pad area, well beyond, close to the area of the tonsillar bed. So those are considered to be high-risk sites. The buccal mucosa or the cheek mucosa in the middle of it is not a high-risk site, for example, because this is an area of continuous friction. So moving on to the next part of this presentation, how to perform a biopsy. Some practical tips on how to perform a biopsy. So in general, a biopsy will start with the local anesthesia, selection of the most appropriate site, do an elliptical incision, engage the undercut of that elliptical incision, and then acquire the tissue or collect the tissue, and then obviously suture. Now please pay attention that when you use the forceps, the tips of the forceps must actually engage the connective tissue. This is a common mistake. If we are too shallow, if we are holding on to the epithelium, we will just rip off the epithelium. The pathologist will not be able to make a diagnosis. The tips of the toothed forceps must actually go in the connective tissue, engage in the connective tissue in the undercut, and then have the tissue retrieved. Otherwise, there will be inadequate diagnosis or, more worrying, wrong diagnosis, in which there is an actual pathology, could be serious pathology, but the pathologist did not see that. This is for the white lesion, white patches, and so on. But when it comes to polyps, there is some also technique. If it's a soft tissue polyp, like a pyogenic granuloma and so on, it's easy to be removed. However, we have the mucosal, which is more critical and takes longer time to remove. For the mucosal, we have to engage the cyst from underneath. We cannot just cut it, otherwise it will recur, and it will continue to recur. To remove it completely, we have to engage the cyst from underneath, and then we have to go down to the connective tissue and collect the minor salive glands. Be careful, the lower lip is highly innervated, so we have to warn the patient about the possibility of paresthesia or anesthesia in the area of the biopsy following the biopsy. The collection of the cyst has to be complete. If it is broken, there is a high likelihood of recurrence. And we also have to include the minor salivary gland underneath. So after we remove the cyst, a minor salivary gland in the underneath, sometimes I collect 3 or 4 just to be on the safe side in order to prevent the recurrence. If we're suspecting an autoimmune disease, then we definitely need 2 biopsies. One is the lesional, the other one is the perilesional. The lesional biopsy is for formalin, for H&E staining, and the perilesional one is from a healthy nearby tissue. And this is done for direct immunofluorescence in order to establish the presence or to prove the presence of antibodies in that area. Masses, be aware of vascular lesions. If you suspect that this is a vascular lesion and you decide to perform an incisional biopsy, the patient will continue to bleed for hours, and nothing will stop the bleeding unless the patient comes back again, and then we do a complete excision. So if this is a vascular lesion such as pyogenic granuloma or peripheral giant cell granuloma, then the entire mass has to be removed as a whole to prevent post-operative bleeding. So moving on to some precautions, what to be aware of when we perform a biopsy. The first thing is we have to look into the site of the biopsy and the lesion of the and the lesion. What does it if it represents a vascular lesion, then we have to take into consideration the likelihood of post-operative bleeding. We have to warn the patient about the possibility and to be prepared ourselves to deal with that in case it happens. Selection of the most representative area is something very important, which I'll focus on in a few moments. Avoid vital structures, so we have to know our anatomy, and we have to know what is underlying this tissue, whether there are some important nerves, whether there are arteries, whether there is a duct for a major salivary gland. Taking a biopsy from those areas and doing some surgical harm to those structures might actually result in permanent damage, which can be problematic to the patient. Avoiding surrounding normal tissue, we'll talk about this in a minute. Do we really need to include normal tissue when we do a biopsy or not? I'll discuss this in a minute. And avoid necrotic tissue, which will really confuse the pathologist when they see excessive necrotic tissue with heavy microbial presence, and this can present in a slightly different structure, a slightly different conclusion at this pathological level. So first, if there is a lesion, the lesion appears to be vascular, then we really have to make a judgment whether we need to remove it in the first place, whether we need to do further studies such as ultrasound for that area, and what to tell the patient in terms of the possible outcomes. There is the simple test, which is diascopy, to differentiate between hematoma and hemangioma. The majority that we deal with in the oral cavity are hematomas, but every now and then we get a case of hemangioma. Selection of the most representative site is also important. Remember what you're dealing with. If you're dealing with a white patch, then select the area that is whitest of the white. If you're dealing with a slightly raised lesion, so both of those lesions, they carry the risk or the potential differential diagnosis of squamous cell carcinoma. So we also need to collect a sample that is quite representative, that represents the most active part of that lesion. If it is exophytic, then this is the most active part. If it is whitest of the white, then this is probably the most active part, and this will be our selection. Some of the common mistake is to include normal tissue, and that can also result in the wrong diagnosis at the lab level. You've collected the tissue, you're sure that you have included part of the potential cancer. However, the sectioning error in the lab is there and is a possibility. Taking a biopsy from the center of that lesion, if it is necrotic, then this will result in extensive autolysis, and this is what the pathologist will see, heavy microbial growth, and this can lead to the wrong diagnosis. And avoid normal areas that are normal. For example, in this image here, the bottom part of the ulcer is close to the lingual nerve, which can result in numbness in the nerve if it is cut, and to the Werthin's duct, which is the duct of the submandibular gland, if it is damaged. And again, this will result in problems in the major salivary gland. And also, it's an area that is rich in sublingual salivary glands. Also, the damage there can result in ranula or a cyst, a mucosal.
You have 1 minute, doctor.
Okay, thank you. So including the normal tissue, like I said, can be confusing at the histopathological level in terms of the sampling. If you include normal tissue, then the technician in the lab will not see what's normal and what's abnormal. So when they do the sectioning, they might actually section the normal part and present the slide to the pathologist of the normal tissue, while just 1 millimeter away is the cancer. So for this reason, I always advise that don't include normal tissue. The only time when we need to include normal tissue is when we want to diagnose autoimmune diseases, because we have to include, or we have to have a different biopsy of the perilesional tissue. Cases of advanced cancer, be careful with those because the anatomy is going to be completely disturbed. So this is a CBCT scan that you see here, and the entire maxilla has been replaced with a tumor. This means that the anatomy has been completely different. So take into consideration that the artery that we know of, the infraorbital artery, is now somewhere else. And it is possible that during the biopsy, this might be injured and might lead to bleeding. So this is the outline. We talked about when to perform the biopsy, how to perform the biopsy, and precautions that we should take. In summary, Sample selection is very important. Avoid normal tissue and avoid necrotic tissue. Autoimmune diseases include perilesional tissue for the direct immunofluorescence. When taking the biopsy, be aware of vital structures. And once you take the biopsy, collect it, don't just put it in the formalin, just spread it gently on a piece of paper so that when the pathologist receives it, they receive it in its anatomical status, not as a twisted or as folded piece of tissue. With that, I finish my presentation, and I thank you very much for being here in this session.
Thank you, Dr. Sahil, for the excellent presentation. Now we will start another topic with Dr. Zohdi. It's my pleasure to introduce Dr. Zohdi Khalid Naqshbandi. He is a consultant in obstetrics and gynecology, specializing in gynecological laparoscopic surgery, consultant in gynecologic oncology in Latifa Hospital in Dubai, United Arab Emirates. Dr. Zohdi will talk about HPV vaccine and genital warts. Where do we stand? Welcome, Doctor.
Assalamu alaikum wa rahmatullah. I'm happy to be here today, and I thank the organizing committee for inviting me for such an important topic in my belief. Sorry. Yes. So I'm a gynecologist originally, and then I specialized in gyne-oncology, and it is related to somehow for the genital warts is the cause for cervical cancer is the same family of viruses that we have been studying for a long time, and alhamdulillah we have a good experience about it and good knowledge, and I think it is one of the breakthroughs in medicine that we have a vaccine about it, and it's also a peculiar type of vaccine. It's not just like the usual life attenuated one, or it is the dead vaccine. No, it is just a virus particle or virus-like particle vaccine, and it's been there in the market and in the medical field for a few times, and we have a good experience now about it. And we want to now evaluate how does it work, and I will start by this. So, just as to know what is the burden of such infection, which is usually very silent, and incubation period is taking a long time to get the effect, and then affect the tissue and affect the cells to have the effect of it. The important for my specialty is, as you know, sorry, I think the pointer is not working. So you can see that these are the cases that have been annually discovered and diagnosed due to HPV, including the anal cancer, and of course for us in the gynecology is the cervical cancer, and you see the numbers are very high with that. We have also the vulvar and vaginal cancers. We have the oropharyngeal cancers, which is renderized, yes, and we start to see them more and more. But look, these are the numbers in thousands, but here the numbers are in millions, and we can have them. And you can see them here in millions. And this is where the effect, and this is where we as gynecologists meet with the dermatologists, because we see these cases and we get in, and we collaborate between each other. Because one of the things also that it can have here is as an obstetrician also following patients when they are in their pregnancy, these are flaring also, and we can see them, and they can affect the mood of delivery, the patient's condition, the patient's psychology and trauma and all these things. As you can see, it's millions of cases, and with the pre-malignant conditions here in the cervix, again, we have millions of cases. And as a gynecology, we see a lot of them that can be contributed to that. Okay, good. So I'll try to move fast, but this is the cervical cancer, okay? And this is the thing that how is the patient report feeling socially isolated, being abandoned, and especially by their intimate partner, of course, and also in the genital warts, okay? Females and males, there are more than 80% reported moderate to high psychological impact. So it is not a deadly disease, but it is really disturbing. It is time-consuming. It is stressful. It's affecting the relationship between the partners, okay? And later also might affect the functionality. We don't want that. We have the vaccines, alhamdulillah, for a long time. So we have, and I'm sure you all know, but I'm going to just go through it, the bivalent, which covers the 2 high-risk HPV, which is 16, 18. And then we have the Gardasil, the quadrivalent, okay, which includes also the low-risk HPV vaccines, which are responsible for the genital warts. And also we have the newest, the nanovalent vaccine, which has the HPV 66 and 11, which is responsible for the genital warts, and also the increase in the number of the ones causing the cervical dysplasia and cancer. We have here over 10 years now with the Cervarix, the bivalent, and more than 9 but this is few years back. We have them more and more now. I have some reviews I would like to share with you. I will start with this one. It's about long-term effects of the HPV vaccination in clinical trials and real-world data, and this is systemic review. In this systemic review, they have these studies that have been involved, especially the Australian study published in 2015, and this one, the Future 2 study, okay? And why I'm referring to that in particular is because the follow-up is more than 14 years now, and in the Australian study, it is more than 9 to 10 years. There is also the Danish study, okay? And there is also another study here which is having a good impact. So in summary, about all these studies, we found that for females 16 and 23 vaccinated, okay, over 14 years for the high-risk cervical lesions or vulval cancer, the effectiveness is 100%. We did not see any cases, okay? For the males who have been vaccinated 16 and 26 years of age, for the external warts or high-grade anal precancer lesions, the effectiveness is 100%, okay? We did not see any cases. And the seropositivity, that means there is an antibodies in the blood are measured. We have it as 91%, and here as 93%. Females and males aging from 9 to 15 years of genital warts or cervical precancerous lesions, again, seropositivity is 89%, and the effectiveness so far is 100%, okay? And if we want only for the females, cases of genital warts or CIN, seropositivity is about 80%, and it's effective. So it is effective. It's been shown that it is effective. And this also another showing the genital warts or high grade for the females and males with this over 10 years, we still have effectiveness of 100%. And this is another study over 8 years for the females for the CIN and the cervical cancer it is. But still, we need more time, especially for the cancerous and precancerous lesions. But in terms of the genital warts, I think it's clear, it is effective, okay, and it is 9. Those are the countries that are being observed how is the declines in these incidences. Our main things here, we're talking about the anogenital. We see the Norway and the Australia, Canada, sorry, Italy, Denmark, and Canada. All these have been shown that there is a decline in the incidence of anogenital warts, okay? Especially the first 2, because those are the ones who had the policy of gender-neutral vaccination. That means what? From the beginning, they started vaccinating both boys and girls, starting from the age 9 to 12 in the school. And those are where, and in Australia, they are very ambitious. They say we are going to eliminate anogenital warts by 2026 or 27, and precancerous diseases within 2030. So this is a very good ambition. And this has been shown, the incidence of anogenital warts, okay, in these countries, like in Swiss and UK, and the United States, it has been decreased in the female and the male, okay, as you can see here. The degree of decline in the incidence in the females is attributed to more females have been vaccinated more than male, because and until now, in a lot of countries, they are concentrating on vaccinating the female. This is just for the other cervical or vaginal diseases. There is also a decline in the grades have been found, and the incidence of the cancer itself has been shown to be decreased in these countries. I just go through quickly. Now, it's a vaccine. Some people will say a lot, and you just go into YouTube and write HPV vaccine. You will find a lot of controversies and symptoms and signs that have been claimed to be due to the vaccine, okay? It is nothing of that kind. These are only have been shown to have injection site adverse reaction, pain, swelling, erythema. This is for the girls, and for the boys the same. So it's really not very bad side effects. There are some concerns, especially with our department and the OBGYN, about how safe is the Gardasil. I will take it as an example because now it's the most common used and recommended HPV vaccine. So we say it's category B, okay, that have been, studies have been shown in female rats does not, at the doses equivalent to the recommended human doses, showed no evidence of impaired female fertility or harm to the fetus, okay? But of course, no adequate, well-controlled studies in women. So even in the brochure, they advise not to take it before a patient wants to get pregnant. This is another study I would like to share, okay? It is translated about changes in the prevalence of the HPV genotype in the genital warts since the introduction of the vaccine. So we want to know what are the types that are the newly diagnosed genital warts. So this study, they have been trying to see what's the prevalence of the types, okay, after 10 years of introducing the vaccine. Now, all the types of the vaccines are having the HPV 6 and HPV 11, which are responsible for 90% of the genital warts. So we want to know now, after 10, 11 years of using these vaccines, what are the types are present. So they used an observational and retrospective study, okay, in the Department of the Dermatology from this year to this year. Let's see what's going on. The results that they have in about 362 diagnosed with genital warts during the study period, and these 212, they underwent genotyping. The most common are these 6, 11, 16, and HPV 42. And the DNA detected in about 93% of the samples, okay? So at least there are 2 of the 4 HPV types targeted in the original vaccines were detected in about 94% of the patients. And this is the diagram showing still the HPV 6 is responsible for a lot of those in the study before we start the new one. Now, this is the current study, and this is the incidence in the 10 years ago from the study. So you can see here, the percentage of the HPV in the 6 in the genital warts was almost 55%, okay? But in the current study, it is less, all right? Also, again, the other one is 11, HPV 11. It was responsible for 29%. Now, in the current study, only 30. And if you can look here now more and more, okay, these are now getting more and more getting a reason, which is HPV 42. Before that, it wasn't there, okay? So we can know that now the HPV 6 and 11, which were the most common, they are now coming less and less because of the vaccines and the giving the protection against them, okay? So the conclusion of that study, that compared to 10 years ago, the prevalence of HPV type included in the first 2 prophylactic vaccines have decreased, which have been shown that, okay? Also observed that slight increase in the infections with multiple HPV types, at least also 1 high risk. So it's not only the low risk, high risk can cause some genital warts, and we have to be careful about that. Okay, due to the time, this is another study in Estonia. I'll just go through it quickly for the conclusion. They used a model to project what will happen 100 years after the vaccination, okay? And this is what they found. It's interesting. So if this, for the genital warts among female, these are not vaccinated, okay? And these are taking the routine vaccine. And this is the incidence per 100,000 year. And you can see if we use it with the same data, it will have a decrease. And also, again, the male, if there is no vaccination, the incidence is the same. And if with the routine vaccination, it is going to go this low. This goes also to the counterpart, which is 16 and 18, causing the cervical cancer. Continue the vaccination, it will come down, inshallah, in the next 100 years. And this was the conclusion of that, is that routine vaccination of the 12 years girls with the HPV 4 appears to be cost effective in Estonia, in addition to providing both short-term and long-term health gains. I will skip this meta-analysis. It's almost talking about the same, and I will just go ahead with the last two slides, because I'm also, yes, this is just from that meta-analysis. As you can see here, it is showing more with the
less than 1
procedure.
minute.
Yes, I'm finishing. Thank you. Okay, so what have you done? You've done something. Wallah, I'll finish. Wallah. Sorry, خلاص, finish. Just at the end, where were we? Yes, I want to show this last slide. Sorry, I have to find it, because this is the main of the topic. So what is the situation so far is we have about more than 140 countries, okay, getting the vaccine. Now, some of them are having very good coverage, like about 80–90% of the girls in this one, and others are still staggering because of, who's going to pay for it, all these things. But the main problem here now is how much is the coverage after all that. From 2019, they found that only eligible male, 4% in the world are vaccinated. So we're not doing so good in that. Females, better, but still 15% is not enough, okay? Especially if you're talking about the cancer. I'm talking from the cancer statistic. I need more than that, okay? And you can imagine in genital warts, which is more common and more problematic for the patients in terms of the healthcare and things, we are still low. So we need to do better. This is my last try. Thank you very much.
Thank you, Dr. Zohdi, for the excellent presentation. Now I would like to invite our speakers to the stage for questions and answers.
Yes.
The Middle East and especially the GCC, do you have any incidents or any data to share it with us?
Okay, yes. I have a scattered data that I can just summarize it in one thing, okay? Unfortunately, we in the GCC are very late in starting the vaccination. For example, UAE here, we started this nationally through the whole Emirates in 2018, okay, by the Ministry of Health, okay? And unfortunately, I'm telling you that the coverage is low. We are giving it to the school girls at age of 13, 14, each 2 doses for the female, okay? But we send the consent to the parents, and unfortunately, I heard that the rejection is up to 60 to 70%. So even with this approach, it is not. We're trying through the media, but by the way, the anti-vax campaign in the world is unfortunately doing a very good job in preventing people from taking generally the vaccines, especially after the corona, and also included in our, which is the HPV. Now, this year, 2024, in the United Emirates, we started also vaccinating the boys, the same, at the age of 13 and 14, which is good, going with the general approach internationally to be gender neutral. So that is also good. But the problem is also mainly it is to the local Emirati The non-local, unfortunately, they are not taking it because they're not offered. They say they go to your family physician. They don't go, all right? And even if they go, then the insurance not covering. If you count that the non-local are more about, say, 70% to 80%, that means actually we're not doing much, unfortunately. Now, in terms of the other GCC, in Saudi Arabia, it has been a long time. I'm a Saudi, and since 10 years, we have been asking to get it into the national program. Okay, just started 2 years ago. Okay, we're trying to make the small efforts with small groups to make them encourage the parents. We are approaching the parents mainly to try to do that, and unfortunately, very, very small. That will also include the other GCC. They are still either very infant or not. We have only one particular experience, which is good, in Abu Dhabi. Okay, they started the program early in 2009, 2008. Okay, and they were very nice and kind to give all the girls, local, non-local, at the school, 2 doses. Everything's okay until now. And we got even some people now, of course, 2009, now women are pregnant and they are following, okay? And they say, yes, we have it long time ago, and it was good. I hope we can replicate the Abu Dhabi experience, okay? But we still need more and more. In GCC, I would say we are still not on the right track. I'm sorry to take a long time to answer that, but it is important, yes. Thank you.
So, can I just add, I congratulate you, and I wish you a lot of success. It's a horrible task. You are going to have a pain in the ass problem with this, because there is a great opposition in the society. Oh, come on, we can talk. Still, I played on you among physicians. The mothers, fathers come to be seen by the doctors, and they ask, Doc, what do you think about the vaccine? It's even enough if the doctor makes the gesture, well, the patient wouldn't be vaccinated. Much better results you become when you vaccinate boys as well, because still the fathers in the whole world thinks that they are going to become grandfathers through the heaven, so they don't want to let have their daughters sex, and boys can have sex. Anyway, it should raise awareness and make a lot of academias like that. That's the only way.
So do you think...
I'm sorry, just to show you that, and I'm sorry to say that, but even I work in a government hospital. We have more than 55 doctors, mainly female, because it's a specialty, women's specialty hospital. And unfortunately, I will tell you that some of the doctors, and actually not some, a lot of the doctors, they don't recommend it too. They don't even give it to their own daughters. Wallahi, I have to, sometimes get into the argument with them to the extent, okay, I tell them, okay, yani, what else do you need? Okay, come with me to my clinic, because I run the Gynae Oncology Clinic. Come and see the patients with me. And I have rotations for some of the specialists to come with me. After the rotation, they go and they do pap smear first, and then they vaccinate their daughters or their friends and things like that. But I cannot do that for everybody. They have to trust me. And I tell them, trust me, I'm a doctor with this field. But unfortunately, as the doctor said, it's not only here, it's internationally. The anti-vax, my goodness, they are very good. I think we are still far away, especially in social media. I cannot do my own, even everyone standing along. It has to be an effort governed by probably very good government or very good dedicated organization. Let's just hope for it.
So do you think Gardasil vaccine has a therapeutic role? That is, if a patient with extensive genital wart comes to me, am I justified in recommending Gardasil vaccine as a therapy in addition to perhaps other mode of treatment? This patient is very captive. If I suggest a vaccine, he will almost definitely take.
Okay.
There is no vaccine.
Now, scientifically speaking, there is no proven work that or evidence that it affects the treatment, or let's say shortens the recovery. Yes, yes, okay. Now, some studies say it does, some others they say.
No, there is evidence.
There's? Okay.
Yes.
Mm-hmm.
The answer is yes.
In general, give it, because I'll give you what? I came now. By the way, I was late because I was doing a hysterectomy for one patient, okay? And the reason is a repeated CIN since 2015 to this viruses again and again. First time it was, she did LEDs for the LEAP incision for that. And then 2019, and now 2023, she has it. So she has a repeated HPV infection leading to repeated precancerous lesion. And then I suggested to her, okay, khalas, you have to do something about it. Okay, she said, okay, we'll do the hysterectomy, but she's 49 years old. I told her to take the vaccine because she got it from somewhere, correct? So where is it coming from? So for such patients, when you give them, you are giving them, if it helps in the recovery and the treatment, fine and well, but it's not the aim. The aim is to protect her from the next one. Because even if I did hysterectomy for this patient, okay, I cannot guarantee that she will not have it in the vulva or the vagina, or if it is going to be, like these awkward positioning or something, anal or pharyngeal. Okay, so please give it, all right? And I'm sure you are going to have a problem with the insurance. They would say no. Then please convince your patient. Tell them this is an investment for you to the future, okay?
Can I ask a question regarding herpes? We do see type 1 and type 2 herpes in the genitalia. But herpes type 2 is almost never seen on the face. Is there any possible explanation for that? And the second question is, there are reports of association between Alzheimer's and herpes now. Alzheimer's and herpes. Is that applicable only for the herpes of the face, or the herpes of the genitalia also linked to possibly Alzheimer's?
Well, very shortly, I very hardly understood you because here the echo is such that I heard every 10th word. Anyway, your first part was whether herpes simplex virus 2 can be also seen on the face. Yes, you say rarely, but you cannot, you said rarely, but actually, how much evidence do you have? Believe me, 80% of the cases of the labial herpes hasn't been laboratory confirmed because a lot of people do not do PCR on the labial situation. And there is evidence that there is, well, still it is domination of one, but there is more and more cases of 2 on the labial and 1 on the genital. And, but one of the reasons is that mostly, let's be honest, also, if there is some complication or some pregnancy story, we usually do not do PCR as a routine for the diagnosis of herpes. And I haven't heard your second question. Herpes and? Oh, yes, but this is definitely a kind of neurosequelae of herpes. Once it becomes a kind of neurotoxic, either the varicella zoster or the simplex. But there is practical no impact of the genital herpes and Alzheimer, but there is impact of herpes virus and one of the potential reasons of Alzheimer. But now, as Alzheimer is in focus, they do anything for Alzheimer because they've got immense budget. And even if they find cytomegalovirus or Epstein-Barr, they will associate it. But this, we have to be very careful about that. But thanks for the question anyway.
Okay, at the end, I would like to thank all our attendants and our speakers for the nice presentation. Thank you.